topic is on understanding the impact of dysphagia on our hospital patients here and what treatment modalities we have to take care of any issues that they may have. I'm delighted to say Margie Anick, our speech and swallowing clinical expert. Or as we say in
extraordinaire.
education,
Now, come on, let's
SME, subject matter expert, will take you through the topic today. All right, so welcome and welcome, Margie. I'll have you run over and
Person holding.
fix that.
Trace.
Come on, Trace.
There I am.
Hi, everybody. I expect we're going to get more nurses, but that's all right. I like speaking to my peeps. All right, so we just get this going. Okay. Where am I heading?
I'm here.
You're heading?
You
Okay,
ready?
go ahead, sure.
You tell me next slide.
Go for it.
All right, I'm good at this.
All right, to me, the most important thing about swallowing is for us to understand the anatomy and physiology of it, because I believe that if you understand where it's going, how it's going, what's involved to propel the bolus down, is going to better enable you to understand when a patient is having problems. You'll then be able to equate what you're seeing on the outside to what's going on the inside. So just to cover, a couple pieces of the anatomy for a swallow. This is looking at the head from the side. So we start with the nasal cavity, which is up top, so the nose is there. This is the nasal pharynx, and what keeps food and drink coming from going out your nose when you're either laughing or inebriated and whatever, out of control, is there's the soft palate. This little soft palate, when you're looking in the mouth, is the uvula, as my son would call the hangy ball. What its function is to move up and back. The walls of the soft palate come in, and it actually closes it. So patients with ALS and upper motor neuron diseases lose that control, and so frequently that's an issue. And I'll be going through a lot of diseases and what you'll expect to see with those patients. So, of course, the tongue is here. It's a fan-like projection, and as we're coming down into the swallow, the epiglottis is, you want me to do it?
She's saying I failed.
Twice, we see twice, right? Okay. The epiglottis sits in our throat up like this, and when we look from the side, it looks like it's just a piece of cartilage, but when you look from the front or the back, it's actually a fan-like projection. And its job is to uncurl, come down, and cover up the opening to the airway. This is the trachea, vocal cords are right here. So when we swallow, which I'll show you in a second, food comes here, this flips back, this flips down. There's a whole bunch of peristaltic muscles that have to squeeze, that bring the food down, and it goes down the esophagus. Hopefully not to the trachea. Next.
A lot of pressure.
I'm sorry, I know. Well, I'll trip if I do it. There are 4 stages to swallowing. The first is the oral stage. That's the stage where we're putting it in our mouth, the tongue is starting to move, we're chewing, adding saliva, breaking it up, and all. As it goes backward in the mouth, the tongue moves in an upward scraping motion, sending the food back this way. And again, as you know, at this point, this uvula is going to move up, and this is going to start to flip down. So the food comes over the back of the tongue. This is now in the posterior oral cavity. As it goes down the back of the throat or the pharynx, it enters the oral pharyngeal stage. Here we are. The green is obviously the food, and it's moving down. So you see that the airway that was open here is now closed. The food's coming down. Here's your epiglottis. It did its job of uncurling, and the food is being propelled here into the esophagus. At this moment, jeez, this is not going well. At this moment, I see it on there.
Right.
Just turn that around. At this moment, as soon as it starts to pass right here, the larynx closes. We have so many different levels of protection against aspiration that a normal person could swallow standing on their head, they could swallow lying down, but of course, as you know from knowing me and what I told you or what you've learned along the way, We try to set swallowing up to be the safest possible because things do not line up and the reflexes are not tuned, the muscles are not strong in some of our patients. So, next. Now, and then next again. Unfortunately, just see. No? All right, this is supposed to be a modified Barron swallow that for some reason is not playing. What I wanted to do is to show you when they swallow, you actually see all of these things moving as the food comes down. Take my word for it. I'll show you one on my phone after if you want, but for some reason it's not loading.
And Margie, just to be clear, in this slide,
Yep.
problems can happen at any one of those stages?
Yes.
Correct? Okay.
It's kind of funny swallowing while you're watching this.
I know. My husband would always say I should serve food while I do these. So as you swallow, I want you to think about it, I was doing a lecture earlier this week and I was talking about when people have laryngeal reflux and all, you have to clear your throat a lot, and Dr. Caroli was there and also she starts clearing her throat and I said, there we are. And then Dr. Abemeyer starts clearing his throat and we actually stopped the lecture so everyone could clear their throats and then we went back to what we were talking about. So I do a lot, I work with inpatients, I work with outpatients, but this talk is mainly just dealing with the inpatients because that's what you're going to deal with. So what I've done in the next 2 slides is I've listed the types of illnesses, diseases, afflictions, whatever we want to call them, that will and that can and probably will impact swallowing. So on the first one, it's more of an obvious one. We all know about the stroke patients. When you have a stroke and you have one side of weakness, whatever you see on the outside, you're going to see on the inside. So that if you've got the right facial droop, the right arm is weak, whatever's drooping and weak on the outside, those throat muscles are also going to be weak. And so there are ways of determining whether we can alter the turn of the head, position of the body to circumvent those weaker muscles so that they can swallow safely. With Parkinson's, it comes multi-leveled. You get difficulty in manipulating the bolus or the food in your mouth. You also get weakness in the muscles that are going to squeeze it down, the peristaltic muscles, and then you also get a decrease in the ability to close the vocal cords. So when the vocal cords can't close, can't protect the airway, you have a higher possibility of aspiration. Multiple sclerosis, ALS, as I said, I could spend an entire day just on talking about the actual diseases and how it's going to present, but I want to give an overview. With dementia and Alzheimer's disease, it comes in many forms. You have what I call a cognitive dementia, meaning you put food in the patient's mouth and they just look at you. They don't really know what to do with it. Sometimes it's related to a lack of perception of understanding what's being put in their mouths. And the example I give is if I was feeding someone, I was feeding you, Cindy, and you saw that I had a delicious bowl of chocolate pudding, and I scoop it up and I say, open your mouth and close your eyes, and you close your eyes, and I switch out and I put in a spoonful of sand. What's the reaction? You're going to spit it out, you're going to be madder than hell, and you're not going to be a very happy camper. So some of these patients with Alzheimer's and with advanced dementia, they cannot identify what's being placed in their mouth. We do a lot of cueing, we do a lot of talking, we do try and incorporate smell into it to bring them to the moment of eating as best we can. The other thing is their taste buds. You know, some people, I just was with a patient. The patient has lost her sour and her sweet. Everything only tastes salty. No matter what you give her pudding, you give her anything, all she will taste is salt. She's not eating very well. So that's an aspect of that. The advanced age, the failure to thrive, the poor appetite has a lot to do with all aspects of the body systems. More often than not, which we'll get into a little bit later, it's more of an esophageal issue. When the peristaltic movements don't go as strongly as they need to, and therefore the food sits in the esophagus, people cannot eat if the esophagus does not clear. So a lot of these patients will have a little piece of toast, a half a cup of tea, and they're done. Only, not because they're not hungry, it's because their whole system can't handle it. Your changes in mental status can be a variety of things. It can be toxicity, it can be, I'm not going to even go into all of that, but it will affect it. No, I'm good. You can move me along. The head and neck cancer patients are a unique group. I do see them as outpatients when they start their chemoradiation.
It's getting ahead of me.
I could kick you when you need to go. Okay, anyway, head and neck cancer patients, what happens with them, these are the ones with the chemoradiation to the neck, to the throat, to the posterior oral pharynx. We're seeing more and more of it. These are the HPV cases. And what happens is with the radiation, you get fibrotic tissue so that where you need the squeezing and the malleability of the muscles to push the food down, it's, one patient described it, said they felt like they had plywood in their throat. Just, it does not move. So we do get involved. All the current research says if we get involved with exercises to keep the muscles moving, even if they end up with PEGs, they will return to eating more quickly than if they didn't. We see trach invented, recently extubated patients. Our policy, not written in hardcore though, is we will not do a swallow evaluation less than 24 hours after extubation. And the reason for that is when they are orally intubated, the tube is going through their vocal cords. So the vocal cords are having to sit like this. You pull the tube out. If patients are older, they don't have the elasticity, so the cords are still going to be like this. This is not a protective cord position. The cords need to be able to snap back together. So we'll listen to their voice. If that's the case, the voice will be hoarse or breathy possibly. They can't get a hard cough. They can't build up pressure behind the cough. Trach patients offer a whole other situation, but we're involved. We do modified barium swallows before we do oral feeding. The latest research, or not latest research, but our latest protocol is that we will not start feeding a trach patient without a modified barium swallow because the percentage of silent aspiration in these patients is great. Their throats have been desensitized, and it's like going on its own. Maybe it's on a timer.
I think it is.
You think it
but
is?
I can't
Okay,
adjust that
that's
now.
all right. That's okay. COPD patients, I think you probably get them in the TCU. One thing about COPD is that, as we know, they're having difficulty managing the in and out of breathing. So when we swallow, like I said, the moment it goes past the vocal cords, we stop breathing. So with COPDers, they get robbed of that moment of air exchange. So whereas we normally, if anybody would like to try it, since you all have something to drink, we will breathe in and out while we're chewing. And at the moment we inhale right before we swallow, and the moment we finish swallowing, we exhale. What do we think? We good? We did that, right? Mm-hmm. Okay. The reason being, it's an automatic protective mechanism. If anything slips in and gets near the airway, and exhaled air is going to push it all away from the trachea, from the vocal cords. COPDers tend to chew and breathe, and they exhale, swallow, and then inhale right after the bolus is passed. So they could be left with stuff sitting near the airway and therefore aspirate. So while they're not aspirating because of weakness or because of a clinically related disease, they will aspirate just because of their own breathing timing. The esophageal disorders, again, I could spend an entire day on them, or night, which I just did. But the bottom line is to know that the esophagus has more of an impact on us than we've ever realized before. So if anything is going wrong in the esophagus, a person will not be able to swallow, or will complain of feeling globus at the top of the neck, meaning there's something in their throat. If it's not cleared out, be it from a stricture, be it from esophagitis, be it from poor motility, we can't eat. We had a patient on the 7th floor. I was asked to see for a swallow eval because, as the nurses reported to me, she holds food in her mouth and she doesn't swallow. Well, this sounds like a case of dementia. I can do this. So I go in. The lady's not demented. We start talking. She coughs horribly whenever she eats. She starts eating, feels a tightness here, feels solid food up here. There's a whole bunch of stuff. I do a bedside, and as we're going through it, I'm listening to her and watching her, and she's swallowing less and less quickly as we're going through the eval, to after about 4 bites, she's holding it in her mouth. We did a modified barium swallow on her, And it turned out that she had almost no motility in her esophagus. She swallowed and everything just sat and kind of just spread out and would sit. And until it went, she couldn't swallow. So it can be what you think it is, but it can also not be. ACSS patients, it's something that we probably need to get more involved in this hospital. Patients, they go in, they go like this, they do their thing to the spine and they put everything back. Well, while they did this, they stretched the laryngeal nerves, they stretched everything coming down through for the swallowing. So patients may have difficulty swallowing and it can last up to 6 months. I see a lot of them as outpatients when they've gotten home and the doctor says, oh, well, it should be fine, and it's not. So I think that's an area we need to kind of get more involved in. So I think a lot of this is obvious, or you know me, and I've said this to you, and I've talked to you, we've talked about it, but I'm going to go through it as if we've never heard this before. So what happens if a patient has dysphagia? I say dysphagia, some people say dysphagia, tomato, tomato. If you were trained on west of the Mississippi, you will say dysphagia. If you were trained to the east, you'll say dysphagia. But whatever. So aspiration pneumonia, we know what that is. All that means is that when they swallowed, food went down the wrong way. Easy. They either choked, they either cough. I'm going to go through what the symptoms are so that it's a little more clear. Another consequence is choking if it's getting lodged anywhere in the oropharyngeal or the hypopharyngeal, which is just right above the top of the esophagus. You're going to feel like you're choking. You may or may not be, but anything that's sitting there is going to make a patient panic. If they can't eat, they're going to decline nutritionally, they're going to have malnutrition. The dietitians, interesting, we really have a very symbiotic relationship. If they see that a swallow eval is ordered, they will not assess the patient now until after my eval. Because more often than not, poor Jackie will write up this entire nutritional thing based on the way the patient can swallow, and I come in and all of a sudden, no thin liquids, or nectar thick, or all these different things, and everything she just did gets thrown out. So they do tend to wait for our eval to see what in fact the patient can and can't eat. Patients can't take pills. That's not uncommon. You'd be surprised at how many people can't take pills. But if they can't, we need to figure different ways. Interestingly enough, one of the main Parkinson issues is an inability to swallow, and Cinemet can't be crushed. So what do? What do you do, Cindy?
I call you.
And what do? Figure a way to get them to swallow. I know, but I mean, that's it. There are meds that can't be crushed.
Yeah, you try applesauce.
We try applesauce. We try pudding. I have a little lady that only liked it in a teaspoon of jelly, and then she swallowed it right down. Or in Jello. I mean, you basically just want something to carry it. But there's a woman in the ICU I just saw today, I forget what the med was, but it was, if you can see the little tiny spot in between my fingers, that's how big this pill was. And I gave it with applesauce, and this little pill, I gave it again, another applesauce, in it goes again. Honestly, I'm talking, it was, this is bigger than it was. I mean, it was the tiniest thing. Spit it again. We finally just crushed it between 2 spoons, gave it with applesauce, and down it went. So obviously it's a crush men's kind of patient. And then the other thing is dehydration, and how many patients come in with that are dehydrated because they started having difficulty, so they started staying away from certain things. The thickening of liquids we'll talk about. It doesn't help if a patient is dehydrated. I can't sugarcoat that to say, oh, it's wonderful. No matter what, if you're drinking a thicker liquid, chances are you're going to get a little bit dehydrated. Next, ma'am. Thank you. Okay, again. What I'm going to go through now are the symptoms. So the first half of this was really just for you to know when you see a patient and this is the diagnosis, it should just, put up your radar to say, hey, there's possibly going to be a problem. Patients will get a dysphagia screen in the ED, and prior to any first oral intake, depending on their diagnosis. But there are patients that are going to come through that don't have any of those diagnoses that trigger a screen, and the doctors will just order a diet. But if you see that any of these diseases that we just mentioned are on there, you know to be a little more careful and to be aware of what's going to be going on. Okay. Thank you. Okay, so I broke up the symptoms by what could possibly be going on. I figured that's a new way to present this. So if there's a risk of aspiration, this is what you will see. And again, every one of these has to do with liquids, solids, anything, getting past all those different valves that we just talked about and hitting the vocal cords, or hitting into the laryngeal vestibule, which is the area of the hallway, so to speak, right before the vocal cords. You've all aspirated, we all aspirate. We actually all aspirate quite often, we don't realize it. But if we do, we're gonna sputter, we're gonna cough, our eyes are gonna tear, we're gonna sneeze. How are you? Hi, good, nice to see you. Thank you. Thank you for doing this. You're welcome. So we're gonna have a reaction, but some people, they're older, they've had stuff going on in their throat, they're not gonna react as well. But any of these things. Now, the thing is that when I'm doing an eval, I will not just give a sip and say they look great and walk out like some physicians will. What I've learned is that because remember the epiglottis we talked about, it makes a trough in the throat, and then on two sides, on either side of the esophagus, are these pockets called the piriform sinuses. So between the epiglottis trough, which is the vallecula, and the two piriform sinus pockets, it'll hold about 6 teaspoons. So you give and you give and you give, and it's all looking great, and they're smiling and they're swallowing and all is great, and now you go to the 7th. I mean, it's not specific 6, it's like something like 6. But then you go to the 7th or the 8th, or you leave to walk out, and then they start laying down again, and either it spills out, or you can only hold so much, and once it starts spilling out, then they're not able to protect. The patient is clearing their throat. It's, again, I'm repeating myself just to get the point in there. It's always because something is getting towards the airway, and this is our ability of making it safe. A hoarse voice, a breathy voice, a gurgly voice. The vocal cords are sitting like this and they're vibrating. If stuff is sitting on top of them and vibrating, it's going to sound like you're underwater, right? Or you'll hear them a little kind of gurgly. That's my impression of being gurgly. Okay. So that's mostly and most often with liquids. It's rare that a person is at risk of aspiration on solids, unless things are really messed up. But going with what we normally would see here, I think aspiration is probably the most common issue that we have with our patients here. But we do have the solid phase dysphagia, which means when you're eating solids, there's a problem.
Did I go?
Yeah.
Go with that?
Yep, that's it. That's okay. So again, you may have the throat clearing, but it's not that gurgly wet sound. It's because they feel like something is kind of stuck in here. May or may not be. Again, it could be in the esophagus, but it's a feeling like they have to clear their throat. They may point to their throat. They may point to their chest. They may swallow and then cough a bit after. Because as it's sitting in the esophagus, the body doesn't know how far up this is going to go again, and so they'll cough just to keep the air flowing away from the airway. Early satiety, I love that word. These are the people that eat and, after that, my grandmother, half a piece of toast and a cup of tea, and she was done. But she was also very Jewish. I am so hungry, I don't understand, I eat so little, but I'm so full. Well, this was like 30 years ago. Boy, do I wish I knew what I know now, because I will bet that it was probably an issue with the esophagus. So, whatever. And then the inability to swallow after a few bites. If it's not sitting in the mouth is clear, it's in here. And like I said, there are so many reasons why we can't swallow throughout this area. As we know, our patients are getting older. A lot more have arthritis. I see people with cervical osteophytes. So I'm supposed to go back to one of my first picture. No, just curious. Can you back? That's one. That one. That's perfect. So this is all nice and straight in here. Looks wonderful. Looks clean. It's a great drawing. What happens is patients have arthritis, and so the points of the spine come out, and they're called cervical osteophytes, and they're usually in this region, which is where there is a sphincter valve that has to open for the food to come down. I've had a cervical osteophyte sit like this in the throat so that when the epiglottis flips down, it can't make it. It can't go down. It bangs on it. So the food comes down and this bangs here and it all collects here. Unfortunately, there's nothing we can do surgery, you would never do surgery on that, you would never do anything about that. We changed the diet possibly to more liquid or some other combinations of things, that's okay. The other thing we'll get at times is because the cervical osteophyte is coming in here, the esophagus gets pushed. So food comes down, it actually has to go around. And again, can't always make it and all. And we're seeing this, we see this more and more with, okay, we'll go back to where we were, I'm sorry. With our older patients.
That's gotta hurt though.
It doesn't hurt,
No?
it doesn't hurt, no, they just, try to swallow and that epiglottis comes down and comes back, but it stays full.
Sometimes it's gotta be more of an uncomfort, like
Huh?
a discomfort, just
It
more
is
of a
uncomfortable,
discomfort.
right, but it's not a pain. Esophageal disorders will give you pain. Patients will comment that they have pain here when they try to swallow because it's not going through. Also, patients with thoracic surgery, that's another area that will experience dysphagia. Open heart surgery, cardiac surgery, the left recurrent laryngeal nerve comes through the chest. They frequently move it, stretch it, it can paralyze the vocal cord and it can affect swallowing. There's a million other surgeries that will affect it. Okay. Sure. So the oral phase is going to be anything having to do with up here. All right, it has nothing to do with anything below, doesn't have anything to do with the throat. If you can't manage your secretions, can you really swallow? So these aren't patients, now we have two types of inability to manage secretions. You have the stroke patient who, because of the weakness and the lack of muscle to kind of suck back up the liquids, will drool. That's not what I'm talking about. I'm talking about the patients with the copious secretions in their mouths that they just can't swallow. These are the patients that when nursing goes in to do mouth care, we'll see all this stuff stuck and dried and all because they're not,
Sorry.
thank you Cindy, because they're not able, their tongue is not brushing back, they're not able to send the saliva back. Excuse me, I guess I moved on to this one here. And so when you look in, you see just this horribleness of dried stuff in there. I had a woman who came in with 3 days worth of fish.
Ooh.
Yes, I know. It probably is 15 years ago and I will feel it as if it was yesterday. And we went in there and, unbelievable. But that to me, I'll walk in and they'll say, could you do a swallow, Val? And I walk in, if I look at a mouth and I see that this is what the mouth looks like, this patient is not swallowing safely. So already, that's one of my signs to say we need to, first of all, clean it up because I don't want to have anything being sent back as we loosen it up with foods or liquids. But anyway. And then the pocketing of food, one side of the tongue, along the gum line, you're feeding them and as they open their mouths, you see it just lined beautifully along the right side of the tongue or it's all in here. It's not a reason not to swallow. It's an education issue. It's feeding on the stronger side, making sure that after you feed this patient that they either swish and spit or use a finger sweep to clear it out. Most often you'll see this, this particular line is really from a stroke, about a stroke patient. I'm not talking about the demented patients that just pocket it and don't swallow. So with these patients, they're able to learn, and so we teach them. We teach them the finger sweep. We teach them, I work with them to move the tongue to get it to do what it needs to do. The reason why they pocket the food is because, and nobody's chewing anything, right? Too bad. All right. When we chew, we use, do you want to chew something? Nobody, are you chewing?
She's doing it.
You chew something. Could you bring it up
She hasn't
again?
swallowed.
I won't do that for you.
Anything but that, right? When we chew, the way we hold food on our teeth is it's the muscles of the cheek, the buccal muscles, and the lateral muscles of the tongue. And that's what keeps it. The tongue's pushing this way, the cheek is this way, keeps it on the teeth. We kind of pick it up, we move it around, and we put it back on the teeth to chew. And the tongue keeps it there. So if you have, let's say you have a left stroke, so you have a right side of weakness, the right side of your tongue is weak, the right cheek is like this, and the tongue kind of like pushes it, and down it goes. They can't bring it back up. We teach them how to kind of suck it back up and make sure that that doesn't keep happening. These patients also frequently bite their cheek, they don't know, they have reduced sensation. Sometimes we will put some wadded up gauze in between the teeth and the cheek to kind of give a little more space. Anyway, okay. So generally, other than those specific examples that I just gave you, we have patients that lose like 20 pounds, but there's no, quote, disease. I have yet to figure out how to lose 20 pounds in the absence of disease. If anyone figures it out, let me know, please. But most often, it's because they're either not eating much, they're only having liquids because solids are difficult, there may be cancer somewhere in the system, but people don't just lose weight, unfortunately. Back again. Thank you. Also, if there's a change in their habits, you know, the husband and the wife say, I don't know, she always ate everything and now all she's doing is drinking soup. Or used to take a lot of people used to take a handful of pills and now can barely take one. I'm not talking about the person who can't take pills. A lot of people can't take pills. And I've actually stopped getting referrals, especially at TCU, for patients swallow valves because they can't take pills. When you ask them, did you ever take pills? No, I can't take pills. So, I mean, I went to chewable vitamin D instead of my calciums or whatever until I started pulling my crowns out. And I figured I'll deal with the bigger pill. But, you know, a lot of people don't like to take big pills for whatever reason. Wow, that's all right. The other thing is what I asked you to do, but you wouldn't, is that they swallow and then, excuse me, they bring it back up. Those patients are usually the ones that probably have this epiglottis that can't clear, so it's sitting there, they can hack it back up, or it's sitting just at the bottom of the throat. Either for a variety of reasons, either because of the cervical osteophytes, that sphincter has a mind of its own, needs to open. If it doesn't open all the way, it won't all go into the esophagus, and you're left with some stuff in the hypopharynx, which is right above the esophagus. Again, not normal. Whenever I do these observations and these symptoms of dysphagia, all I really want to say to you is, if it doesn't look normal to you, it isn't. And that's really as simple as it goes. We know what normal is. We know what normal sounds like or doesn't sound like. You're in a restaurant, you hear someone starting to have some difficulty, we're aware. So we know what normal is, and we know what abnormal looks and sounds like. There are a lot of patients that complain of having a lot of mucus, and this generally has to do with the esophagus. The esophagus has glands that secrete mucus, I guess, whatever. And when anything is wrong with the esophagus, it secretes more. So I have numerous patients who come to me with modified barium swallows, outpatients, that are hanging their heads over the sink in the morning because they can't stop expectorating stuff. One lady stopped going out to eat because she's spitting into a tissue always, and it's too embarrassing, and she's not comfortable eating with family anymore. Modified barium swallow showed that her esophagus was inflamed, wasn't emptying, and it was a whole situation. Okay, so most patients will have this dysphagia screen, which I'm not going to go over now, but in the ED it's done. It's with a variety of different medical conditions. We'll auto-generate it. Sometimes they'll get up to the ICU without having had anything by mouth, so they haven't had the screen. But anybody who fails is not given anything PO, including meds, which took me many years, let's just say, to get that to be a thing. Because I would always say, how do you say this patient is not safe to swallow, yet this aspirin or this Plavix or whatever is going to know where to go? So finally, for the most part, unless it's a very life and death situation, they are not given any PO until they either pass the screen or the eval. Okay. What next? Ooh, guess you can't wait. So, and interrupt me at any point, I will just go on now. So the diagnosis of dysphagia. So the screening is or isn't done depending on the patient. We cannot go into a patient's room technically without an order. I will say that it's not uncommon for a nurse to say to me, could you just take a look and does this look right? And then the benefit of being here for, I'll throw this in, for 31 years, is that I know most of the patients that are coming in that are in their 80s and 90s and 100s because they've been in before. So I may say, oh, Mrs. Jones, she always does that, give her that little teaspoon of jelly and she'll be fine, whatever. But bottom line is, we need a doctor's order to come in for the eval. You've all seen my cart, I wheel around with me, I do a bedside, and by the way, we do have 3 other people. We have Christine, Dawn, and Isabel. We'll do a bedside evaluation, at which point we'll look at Different consistencies, generally it is applesauce, it's peaches, it's some kind of cookie or cracker, and it's different consistencies of liquids. And we will look and see. Good. How you doing there?
I'm busy.
I see you are. You're doing very well though.
Thank you.
And we'll see what's going on. We may determine what diet's appropriate, what liquids are appropriate at that point, or if we're not sure or we feel that we need to see more, we'll do a modified barium swallow. With the modified barium swallow, next.
Margie,
Yes,
so the dysphagia screen is something that's done by nursing?
yes, it is a nursing intervention. Most people know this chair. This is the Halstead chair. However, in transport, it is called the Amigo chair. And the reason for that is when we first started doing these studies in 1993, the chair that we had was called the Amigo chair. It was a horrible chair. It was like a hard black office desk chair. It had very little give. Then, for $6,000, I convinced them to buy us a new chair, and this is the chair we have. And it's called the Halstead chair, but everyone wants to remember it as the Amigo chair, so that's what we call it. I'm not going to get into that. Patients are transported. It is a fantastic chair if you know how to use it, because it will lie flat, so patients that can't transfer can get pulled over, and then the chair is sat up. They would only be transported in 90 degrees position, and with both pieces of the chair intact there. When they come down though, and they get to have the study, next they have to fit into this space. So this is where the modified barium swallows are done. This normally is a table, and it lies horizontal. And this here is a tube and a camera that moves back and forth. So it's called modified barium swallow because we're modifying the way a barium swallow is done. So the table sits up, and the chair scooches into here, back there, and they're facing here, and I'm standing here. This space is only 18 inches. So that's why that chair, we pop off the back. It gives them, I think, a 30-inch base for their bottoms, but it gives us the ability to push in here and have them here, and we kind of switch their shoulders, we bring it next to them, and then they relax. If they're wider than 18 inches, we'll oblique them, and we do a lot to get it done, but they have to be able to transfer or be in that chair. And then this is the camera, and they are given food. I have a computer screen called the TIMS that looks at it, and I will then always show it to the patients or the families, or pop it on my phone without the patient information on it. And we'll bring it up. We've texted it to daughters in California so we can have a conversation. They can understand what's going on. So that is, what's the deal with the modifieds? I give them applesauce, peaches, pudding, bread, crackers maybe, and different liquids. If there is a specific food, I've done roast beef sandwiches. You know, patient tells me there's a specific food they have difficulty with, then I will find that food. I had a patient who only had trouble with raw vegetables. So unfortunately, we got carrots, we do barium, and we're able to see that. I've done gefilte fish, I've done matzo balls, I've done anything during different holidays. Haven't done any potato pancakes though, but maybe I'll try them. But anyway, it's a wonderful study. I love it, and the radiologist that I work with is phenomenal, and we're able to really see what's going on. We do this in two positions. One is sitting in that chair. So we're looking from the side. That was that picture, that video we tried that we couldn't show you. And then we move the chair out of the way. We have them stand. They put their back up against this table, and we're able to watch a complete AP view down to the stomach. So if there's anything going on in the esophagus and any complaints related to that, we will see it. It's not a test of the esophagus. It is more of a screening, just to see is there something, and does this then necessitate referral to GI? Do they need an EGD, do they, depending on what we see.
And it takes about,
The test
How
itself
long?
takes about 5 minutes, 10 minutes, because it's only about 10 swallows. What takes longer on my outpatients is that I spend probably 15 to 20 minutes getting a history and really understanding what the patient is complaining about and what their symptoms are. Then after, so the actual radiation exposure is quick. Fluoro time is usually around 2 minutes total. It's not continuous, you know, you press the pedal, they swallow, you take your foot off, so it's not like you're sitting there, you know, on the pedal the whole time. And then afterwards, I always show the study. because I have a lot of people who come to me and say that they feel like something's stuck, they can't swallow, they're pointing, and I have them actually point in the modified so that they can see their bony finger here and absolutely nothing here, or whatever else is going on. So I probably spend 45 minutes with the patient. The actual modified is 10 minutes max. Okay. Alrighty, so what do? All right, so, and again, you know these things, but we're going to go through them anyway. To decrease the risk of aspiration, positioning is possibly one of the #1 things. I have had people that they tell me that this patient is coughing and sputtering and having difficulty, and I walk in and I see them eating and they're basically, 30 degrees, they're what?
Semi-Fowlers.
Absolutely, good word, thank you. I go like this. And so you get them sitting up, you prop them up. By the way, don't put pillows behind the shoulders because then their heads just go like this, which increases the possibility of aspiration. So you want the heads to be straight. And then the no straws thing. It comes from, I think, more than anything else, experience. I don't think that research is showing that those who use straws aspirate more than those who don't. But 2 reasons I say, in our hospital, we approach it as rule in straws rather than rule out straws. Because older people have lost the fat inside their cheeks and the tongue strength, and so when nobody has a straw, whatever, when we use a straw, we suck up, we use our cheeks, we use our tongue, did you do it? You did, good. And we don't have we could be holding our breaths and we can still drink with a straw. Older people or advanced age people, will go like this, because that's the only way they can get the liquid up. So now if they're going, their airway is wide open, and so then they're at risk for aspiration. The other issue with straws is that if you're using a straw, you can drink in any position. You can be completely lying flat on your back, and you can get a straw stuck into your corner of your mouth, and you can drink. Well, that's obviously not the best idea for these people. So if they're not using straws, they have to be sitting up to drink from a cup. So it's kind of a roundabout way of making sure, rather than say position the patient well, I just say no straws, and then nursing has to make sure that they're sitting up in order to drink from the cup. So diet changes, we all know about the purees, the chopped, the mec soft, and the regular. There's reasons for all of this, and whether it's patient doesn't have their teeth, patient has weakened mouth. With the stroke, they're not used to how their tongue is going to interact with the food and what they're going to do. It could be a patient we just had on 7 that was impulsive. He could chew fine, he could swallow fine, but he would throw the entire meal in his mouth in one shot if we didn't make sure that it was, if it was chopped and easier to eat. So there's a lot of reasons why we would change the consistency of the diet. I believe that I want people to be as close to normal as possible. I won't just stand on ceremony and say, well, it's either to scoop puree in than cut the food or watch them or help them. It's more important that they be as close to what's normal for them. The liquid consistency is a real hard one because nobody wants a thickened liquid. We happen to have a phenomenal product now at the hospital, I'm proud to say, the Simply Thick stuff that we use. But I know there was a study once where they had graduate speech pathologists have to have a nectar thick liquid for a week. They lasted 3 days. I mean, what does that tell you? You're even doing it for research, and they couldn't do it. So you think about how nasty it really is. It's not, but we have to do it. And so we will see either in the modified Barrow swallow or bedside what is going to be the best consistency. I don't really believe in pudding thick. Because I think anything that's pudding thick, once it's in your mouth and it mixes with saliva, it's going to get looser anyway. But sometimes, rare, we have to do that.
How do you even get pudding thick here?
Two yellow packets. 2 yellow packets. So,
I'm surprised though, when you thicken them up, patients are like, oh, it's so much better.
well, and that's the thing. This woman that I was asked to see, that's okay, the woman I was asked to see that was holding food in her mouth, when I did her modified, she actually was swallowing okay, and she really wasn't aspirating or anything. She preferred nectar thick liquids with her meals because the nectar was heavier. and it would actually push the stuff down her esophagus into her stomach much more easily than just regular liquids. I saw her original modified was at the beginning of February, and today's Thursday, on Monday, I saw her for an outpatient to see if she still needed these nectar-thick liquids. And the reality was she didn't, but she chooses to use them during her meals because she feels that it's like a plunger, it pushes things down more easily. The other thing I don't have up as a source or a possibility is something we call the Fraser Free Water Protocol. So let me just get through this one and then I'll talk about that. So the reason for thicker liquids is that as you're drinking this water here, it just splashes down. It goes willy-nilly. It does not hold together. It doesn't stay formed. Excuse me. It goes where it wants to go and it splashes down. So if there is anything that keeps these boluses from being contained and kept together, being any kind of muscle weakness, decreased sensation, people are going to aspirate. Then the various valves that need to close are not able to operate, they can't move quickly, they can't close quickly enough, and so the patient aspirates. And that's the reason why the thicker the liquid is, the slower it moves, and the more easy it is for a patient to actually handle it as it travels down. Okay. And this is just telling you what we have at this hospital for our nectar, honey, and pudding with the Simply Thick are the packets now that we have. We have pre-thickened juices. We have Magic Cup, which is a supplement, and it comes frozen. I'm sure you all know it, and it melts into a pudding consistency. You can always go eat something that's thicker. You don't want to over-thicken, but if a patient is on a nectar thick, they can have a gelatine and a Magic Cup because they can't have regular ice cream. They can't have regular Jell-O. Those things actually melt into a thin liquid. Gelatine has 20 grams of protein, so as a supplement and as something that stays thick, it works. So all our liquid supplements can be thickened. The old products we used could not, so this is new and this is exciting from a dietary standpoint. And soups are not normally thickened, they must be thickened, either as determined by me or the physician. Now, what is my next slide, just for a second, because I want to, oh, okay, you can stay there then. These are just what the packets look like. The bottom packet gives you a honey consistency for 4 ounces, and the top one gives you a nectar thickness. I'll tell you a secret, actually, 2 of the pink equals 1 of the yellow. So when I have families that are very, very with it, I will let them, I will share that knowledge with them because then they are only opening 1 packet instead of 2. It also comes in a big pump. And 1 plunge is nectar, 2 plunges honey. And so if someone goes home on that diet, they will order that big plunger thing. It's a lot easier.
Want to hear something?
Sure.
I've dealt with these packets for so long and I could never remember which one was thicker. I just now realized that there's a 2 and a 3 on them.
There's also more and less.
Right.
Well, like the pink is smaller than the yellow.
Yeah. Well, when you're not thinking about the
I
size of the
understand.
packets when they're
Right,
like.
and then it
trying to
says
figure out
that
what
there's
to
a
grab.
honey bee, get it? Honey bee
honeybee,
and
the
nectar flower. Yeah, okay, that's all right, you're busy.
I've asked several times, which one's thicker?
I know, that's all right. One other thing that I will, and possibly to the TCU patients come, which is important to know about, is the Fraser Free Water Protocol. So what that is, it is absolutely evidence-based, researched up the yin-yang to say that patients who are at risk of aspiration on thin liquids, so they need either a honey or a nectar, in the absence of a respiratory issue, so let's say they had pneumonia, they're all cured, they're all fine, now they're just going for rehab, or never had pneumonia, they just needed the thicker liquids, can have thin water, plain water, ice, and plain seltzer, and will not develop pneumonia. However, the only issue and the only condition is they must have very complete mouth care before they do that. So this is not something that is done during meals, because meals you have food in your mouth and all this particulate stuff. So the meals they have whatever the thickened liquid is as it's supposed to be. But the, excuse me, but once they're done in between meals, and this saves them, it absolutely saves them. They can have cold water, they can have seltzer, they can have other things, I said, that's all. Ice water, ice, and plain seltzer. But it truly, they can't have their martini, they can't have their Jack Daniels, it has to be thickened. But it does save patients. And so if that's the case, we'll educate you. We have signs, we have charts, we have things that get put up in that case. Very quickly, I'll give you an anecdote. When I started here, which we already know was a long, long time ago, in a galaxy far, far away, we did not thicken liquids. So if a patient could not tolerate a thickened liquid, they laid in bed forever on an IV. Patients would be here for 3 weeks, 4 weeks, just because they needed to be hydrated because they couldn't drink. So I came in all young and excited about what we could do for these patients, and I realized these products were out here, and that's when we started using Thicket, the original Thicket, which again, we've come a long way. But so when I brought it to the hospital, we went through all the committees, I said, I have to try this, I have to see what the deal is. So I brought it home. At the time, my husband was the only person I could really torture. My son was only a year old. And I took out all the liquids I could think of. And one of them was Jack Daniels, because that's what he drank. We did Jack Daniels, we did juice, we did hot, cold, whatever. And I made his Jack Daniels a pudding thick. So he comes home, he looks at me, he knows me, he goes, what are we doing? I said, you've got to try all these things. So he goes in the corner, he sits down with his spoon, and he starts eating his Jack Daniels. And he sits there. I said, Andrew, you need to now move along to the other things. He goes, just a minute. And so you know what it did for me is it made me realize, and I do this with every new product, I bring it home. And then as my kids got older, I tortured them, and every meal they'd sit down, there would be like a new packet at the dinner table, they'd go, what? So finally, when my youngest son was 18, which is maybe why he moved to California, he finally said to me, I don't have to do this anymore, I am 18. You cannot make me do this anymore. He did, but whatever. So we try these things, and there are people, they have martinis, they drink, they have lives, even if they can't handle a thin liquid, so you gotta do what you gotta do. I don't need to say that, we can read it?
Does he continue to drink his,
Do I thicken his liquids? No, I don't. I do cut his meat, but that, no. Only because he's sitting in a recliner. Anyway, we're not gonna get to that. Okay, for patients at risk of aspiration, the most important thing you can do, I could circulate article after article after article. The most important thing you can do is oral care. Goodbye. You're welcome. And because if the bacteria sits, it's not getting flushed out because they're not drinking, they're not changing things up. Oral care is the most important thing that can be done. Dentures need to be taken out, as nasty as it is for some people to do. They have to be taken out and cleaned. Please do not stop thickening liquids. Don't just say, well, let's just see how he does, because that slide before was, if it's silent aspiration, you will not know. I have a physician who insisted on coming in and handing his patients glasses of water and say, see, he's fine. Unfortunately, the nurses would come to me and say, Dr. So-and-so just came in and did this, and I said, did he look at the whiteboard that says silent aspiration? Anyway, next. These are not toothbrushes, in case anybody doesn't know that. They're for people that don't have teeth, or just need their mouth moistened. You want to kind of give a little scrub of the tongue or the gums or anything like that. These are not toothbrushes. I ask you to take a couple home, I'll pay for them, and brush your teeth for 2 days with these, and tell me how your mouth feels. I can't tell you, this was a crusade we had a few years ago about oral care. How many people thought that these were good enough to go and brush the teeth with? They're not. So we have the Sage, is it still Sage? For a while that stopped, I think.
whatever the title is, I think it is.
Okay, whatever. We have suction toothbrushes.
Yeah.
Inability to deal with thin liquids. It doesn't mean we gotta have them hanging over a sink. We have suction toothbrushes. We can brush teeth. No matter what, teeth can absolutely get brushed. And that's probably the most important thing if you come away with anything. So I evaluate them. I do oral motor exercises if I need to strengthen up the muscles. We could do postural changes. Compensatory strategies, changing the way that they eat, alternating liquids, solids, changing the consistencies. I have airway protection exercises, basically throwing the vocal cords together, strengthening that adduction movement. Some of the postural changes is if there's a stroke and it's weaker on one side, you turn your head to the weaker side and you bring your chin down, and what it does is it actually closes off that side of the swallow and lets the strong muscle send it down. So if you are approaching a stroke patient and you see one side is weaker than the other, I would always approach from the weaker side so that they're forced to turn their head already to put that into place. All right, and then that's it. That's pretty much all I have to tell you. Questions?